next, so we start the CMT section now, and our next speaker is Professor Attarian, who will talk about the neurological aspects of CMT.
Thank you very much for this invitation. I'm very honored to be with you today and talk about Charcot-Marie-Tooth general aspects and some words about therapy. Charcot-Marie-Tooth has been described by three neurologists in 1886, two French neurologists and one English neurologist. CMT is the most common hereditary neurological disease and it's very frequent. So the frequency is about 1 out of 2,050. In France, nearly 30,000 people are affected, and I should mention that it should be distinguished from ALS, amyotrophic lateral sclerosis, or Charcot diseases, which is a very fatal disorders, and it is confused by patients or by some doctors with CMT, which is completely different. These neuropathies are very heterogeneous, hereditary, neuromuscular progressive diseases that do not affect life expectancy. So they affect the peripheral nerve, often causing amyotrophy of calves, forearms, and hands. So CMT, as I told you, there is a very heterogeneous pathology. Under the same name, we find diseases due to different genes located on different chromosomes, but the clinical pictures and signs remain more or less the same. This is an example cartoon to show you that the genes are spread among all the chromosomes. In Marseille, in France, we detect more than 100 genes for diagnosis. So there are several forms of CMT in function of the mode of transmission, genetic location, and the part of the nerve affected. Three major families. Type 1 is dominating type, have a slow nerve conduction speed velocity because the myelin sheath that surround the nerve doesn't function correctly. CMT type 2 is called axonal type, have normal conduction velocities, and since that the problem lies in the axon and not in the myelin sheath, and X-linked CMT have abnormal myelin and slightly slowed conduction velocity. In addition, the transmission is different from CMT1A and 2. Moreover, each of these subtype is then subdivided into subtypes, 1A, 1B, 2A, 2B, and so on, according to the genetic causes, the gene affected. So how is CMT transmitted? Dominant transmission means that the neuropathy is transmitted by at least one of the parents. One of the parents is himself ill, sometimes without clinical sign. Each of his children, regardless of sex, has 1 in 2 risk of inheriting the abnormality. Recessive transmission, both parents who are themselves healthy healthy carriers must be carriers of the genetic abnormality. Their children will have a 25% chance of being free, or 50% risk of being healthy carriers, and a 25% risk of developing the disease. And finally, X-linked CMT is of maternal transmission. How do they manifest? So the age of onset of symptoms vary widely, most often in childhood or young adults. The early and severe form of CMT has been called Dejerin-Sotas disease. There are sporadic forms. There are also a few cases of spontaneous genetic mutations without any manifestation of the disease known in the family, as well as cases where hereditary transmission is difficult to discern due to the lack of information about the family. So the first signs generally concern the feet with digging, pes cavus, and sensitive and not very. The patient are the feet are insensitive and not very stable. Little by little, distal motor weakness appears with steppage, causing falls, sprains, difficulty in running, the walking perimeter narrows. Tendon retraction can cause the claw-shaped toes. Amyotrophy of gives a calf, gives a characteristic appearance called Rustal calf. And the hands are not systematically affected, and generally appears, the weakness appears after several years of evolution. 5 movements became difficult to execute. The finger can become again claw-shaped. Amyotrophia can appears and can cause the loss of pincer function, a decrease in strength, with a decrease in strength. In principle, all of these problems are bilateral. Here you can see amyotrophy of these muscles and this region and here. Sometimes we can see hypertrophy nerve here, for example. Cramps are frequent, especially during period of evolution, the progression. The deformities and amyotrophy, as we saw, are variable, but fatigue, unstable balance, difficult standing, difficult stair climbing, and generally diminished manual extremity are constant, in general are seen. So CMT diagnosis by electromyography. The electromyography make it possible to distinguish myelin sheath damage with reduced motor conduction velocities, often less than 38 meter per second, from axonal degeneration, as I told you, type 1 and type 2, and substantially normally motor conduction velocity. So these tests, as I told you, help to determine what type of and subtype of CMT in each patient has. And of course, the diagnosis is performed by genetic analysis from a blood test, and very rarely, at least in France, very rarely we perform biopsy. So the diagnosis approach is based on clinical and EMG expertise, electrophysiological expertise. We try to specify the mode of heredity, to specify clinical phenotype with clinical examination, search for associated extra neurological sign and measurement of conduction velocity. In this way, we can determine different family of CMT and target the genes. For example, here, as you can see, by nerve conduction velocity, we determine, as I told you, that the major families 71A, 71 and 72, after that the hereditary allows that to distinguish different kind of hereditary kind of transmission, type of transmission, and therefore in function of distinct transmissions to target the genes and to do diagnosis. So, as I told you, clinical presentation also search for associated signs in order to facilitate the search for genes and discussion with geneticians. For example, if there is central nervous system sign present, we search for CMTX or deafness for these genes or vocal cord paralysis for these genes, and so on. So how is it evolving? CMT usually evolves slowly, but sometimes in a flare-up way, especially in adolescence, sometimes during pregnancy, menopause, or in stressful situations. Of course, each case is particular. The severity of the disease varies from one patient to another, even with the same family, and there is no way to predict its evolution. We see patients every year in hospital evaluation, do evaluations and try to determine in a personalized way the progression of the disease. So longevity is not affected. The people have a normal life. What accompaniments can we offer? Currently, no. There's no currently no curative treatment. However, it is very important to take preventive measures, especially with physiotherapy, which its objective is to delay the onset of significant deformities and amyotrophy. The use of cane or splints, orthopedic shoes are recommended. Orthopedic surgery are not indicated in adults. One very rarely are used, particularly in the arm, and then the indications are for pediatric in children's, and many various technical aids can be considered. How to live with CMT. So disability is variable and generally allows for more or less a normal life. So the choice of profession is very important, and we can help the patients in their choice in order to take into account possible changes. It's better to avoid, for example, work requiring prolonged standing or a lot of moving around or requiring great manual dexterity and so on. The choice of the place of residence also is important, for example, to avoid houses with the stairs. Also, it's important to understand the environment of and the patients and acceptance of the disease, especially in children and adolescents. It is important that they practice as long as the educator is aware of the disease and the limits, and understand the disease and in a position compatible with the handicap of the patient. And also, this is very important for development of children to, as much as possible, to do the same activities as their friends and peers. They found it difficult to be set apart, but accept some compromises if possible. So it is also important to know that the slow evolution of the disease allows a gradual adaptation to the decline in performance, but raises question for the future of the patient. The clinical signs that are not very visible at the beginning, the variable fatigability from one moment to the next, must be carefully taken into account by those around the patients. Psychological support may be helpful for, despite everything, many people manage to lead a rich and fulfilling life by refusing to mortgage the present for the future. And it's important to meet with other people concerning with the disease and to talk with them and to have to share their tricks. In terms of therapies, I will only talk about 3 therapies actually enough in development, advanced in development phase of trials. All of them in CMT1A. Other treatments are available, but I want other molecules, candidate molecules are available to be tested, but they are in a very early stage of development, so I will not talk about them. In CMT1A, there is a treatment proposed by Pharnex, which is a French company, using 3 molecules, baclofen, naltrexone, and disorbital, each of them acting at a different level of molecular level, different molecular level. Finally, the result is to act at the to decrease the production of PMP22. So to have all of them have a final effect. So each of these molecules have some effect, but the sum of the 3 molecules have a additional effect 3 times more in these presentations for in terms of different targets and results. So we have tested this treatment in 323 patients and in 30 countries with these outcome measures, and the results were very interesting because the higher dose showed that the mild improvement in patients in these endpoint measures or 10-meter walk time. So we consider this very encouraging, and another phase 3 is programmed for 221. Another interesting molecule is this one, IFB 088, which is proposed mainly in principle in CMT1B. This molecule improved in animals many parameters in biologic histology or functional parameters, and we performed a phase 1 in 2019. Things were just a little stopped, by COVID pandemic, but phase 2 is planned for the end of 2021. This is a very interesting molecule without side effect. We hope that we can do this phase 2 in patients with CMT1A or CMT1B. Another very interesting molecule is this one. This is gene therapy, but not directly targeting PMP, the gene implicated in CMT1A. So 9 patients have been tested. The results are very interesting. So we hope that a phase 2 will be planned. We are waiting for that. So what is the final message is that the exact diagnosis of a different subtype of CMT is very important to know exactly what is the gene. This is a very important question for genetic consultations and to have the possibility to participate in trials. And the trials arrive and the interesting molecule are and will be tested in very near futures. So we hope for their success. Thank you very much.
Thank you for this really interesting and insightful presentation. And we have a few questions. One concerns drugs that are not recommended in CMT. Are there any?
Yes, so this is a very important question because many drugs have side effects on nerves. So they are not. I mean, many doctors are fearful to propose them and to the patients. But when these drugs are important, for example, drugs used in cancer or drugs even used during anesthesia and so on, they should be used. So I will say that don't be afraid of drugs. If your doctor is aware of your disease and if the doctors know that you have CMT and think that these drugs are important to be used for the care, so they should not be avoided. Many antibiotic therapies, for example. So we see that in France, many people, many CMT patients are avoid to take the drugs, and this is sometimes harmful.
All right. And there is also a question concerning the possible surgery. So if a patient with CMT needs a surgery, are there any precautions that they should take?
Yes, so this is very important that surgeons know that you have the patients have CMT because they have to avoid some positions to compress the nerve, and even after the surgery to take attention to take care and pay attention to the position of the patients in order not to compress the nerve and to increase the injury.
All right, and the last question concerns pain and fatigue. Are they related to the disease? Are they just the regular part of symptoms that the patients experience?
So this is very, very important. As a doctor, I learned that there is no pain in CMT, and this is false. And we learned when we hear the patients, we pay attention to what the patient says, we understand that, yes, pain and fatigue are the major sign of this disease, and the doctor should take to pay attention to these signs and to try to treat them. Then this would improve clearly the quality of life of the patients with CMT, of course.
Thank you so much for this presentation.